I would like to welcome you all to our Med Stories, Lessons Learned, Solutions Sought. And I appreciate you being here. In the US, it's a holiday, Martin Luther King Jr. Day, a day of remembrance of the importance of his advocacy, and often a service day for many of us where we try to engage in an activity that commemorates his mission. And we today have a topic of health coaching and continuous glucose monitoring, promoting diabetes remission. And so the description for our talk today is type 2 diabetes is a global public health challenge, but remission is possible through lifestyle change. The relative importance of feedback, frequency, and support in healthy habit formation remains unclear. In a randomized controlled trial with 95 people living with type 2 diabetes, our guest investigated the effect of continuous glucose monitoring alone or combined with health coaching on implementing low carbohydrate nutrition education at a diabetic clinic. So in this presentation for MI-Med, they'll be sharing the results of this study and the value of health coaching with an MI foundation on diabetes management. And I'm going to send this over to Jody, who will do introductions.
Thanks, Heather. And I'd like to echo just the welcome to each of you, whether you're attending live or you're listening to the recording. Welcome. And we're just so excited to have our three presenters here with us today, Lauren and Kate and Sophia, on this Martin Luther King Jr. I don't know that I want to call it a holiday, but really a recognition of his legacy and challenge to each of us to do better and to be better. And I'd love to just share one of my favorite quotes. There are so many from Martin Luther King, but I think it really ties us into what we're talking about today, and certainly our motivational interviewing in Mint circles. And he said, we must accept finite disappointment, but we must never lose infinite hope. And I just think it's such a powerful quote. Lauren knows how much I love quotes. I'm a collector of quotes and sayings and poems. And I think what a beautiful launch pad into the work of these three women, and as well the work that we all do in our interviewing circles. So we do show up with hope and compassion and accurate empathy and allyship, and truly a privilege to welcome Sophia and Kate and Lauren. And let me read just a quick bio on each of them, because they come with extraordinary and stellar credentials behind them. But knowing Lauren for a number of years, I also know that they come with hearts as wide as the sky for the work and the work that they do. So Sophia Montero is a behavioral economist, is a behavioral economist at the Kiel Institute for World Economy. She is a postdoc in the Global Health Research Group. Her experimental research at Max Planck Institute for Research on Collective Goods explored cognitive biases. Sophia holds a bachelor's degree in economics and psychology and a master's degree in applied economics from the University of Cape Town, South Africa. And she has a PhD in economics from the University of Cologne in Germany. Welcome, Sophia. We're glad you're here. Kate. Kate Larmeth is a researcher and senior lecturer at the Institute for Health through Physical Activity, Lifestyle, and Sport at the University of Cape Town. She holds a PhD from the Institute of Infectious Disease and Molecular Medicine in medical biochemistry, and has expertise and years of research experience in non-communicable disease, protein biochemistry, and clinical research. Currently, her major interest is in the metabolic effects of diet, including low carbohydrate, high fats diet, and lifestyle on clinical outcomes and overall health. So welcome, Kate. We're glad you're here. And Lauren, so glad to see you. So glad to welcome you here. And Lauren is our connector here. And I've known Lauren, had the privilege of knowing Lauren for a number of years through our work together in health coaching and continuing to learn and to grow together and in our motivational interviewing skills. And so Lauren Kim Angelil is a certified functional health coach and physiotherapist. She has a master's in physiotherapy with specialization in behavioral medicine and supports clients to make long-lasting changes through her coaching consultancy, Lauren Kim Wellness. She was first introduced to MI in 2018 under the teachings of our one and only Ken Cravel, and continues to see it as a foundation of her coaching practice, helping people change through holding the space of challenge, curiosity, and compassion. So with that, laying our groundwork, Lauren and Kate and Sophia, welcome, and we'd love to turn the session on over to you. So take it away. Thank you.
Thanks,
Great.
Jody.
Thank you, Jody.
Thank you.
Okay. Screen.
Hopefully it's clear. Yeah, okay.
Okay. All right. Well, thank you for that welcome and that introduction. We're so excited to be here with you all and to introduce the topic about thinking about nutrition behavior when it comes to diabetes remission, which until recently was not even a topic that was thought possible. And now it's something that's very catchy, but we all want to know how to get there. And we all come at this problem from our different disciplines, and I particularly love setting up these interdisciplinary teams, and I also enjoy working with friends. So that's how I ended up working with Kate and Lauren. So nutrition has been central in many traditional forms of medicine, but its role has declined in the last century. And the food as medicine approach really challenges our conventional Western medical model, which tends to focus on things like Ozempic has solved the lifestyle problem. We don't need to worry about lifestyle anymore. And if you read the news in Germany, you think that it's a moot point and there's really no point in having this talk at all. We don't take this perspective, and we're really excited to share our insights from the research in South Africa.
Cool. So, as we all know, there is definitely a growing burden of chronic disease worldwide. And from a purely economic perspective, there is huge value in reversing this trend in both diabetes and non-communicable diseases. And this is basically what drives us. We believe that people can change. And then just in terms of the state of the problem, because I know many of you are sitting in the US, the latest stats from the USA say that about 38 million people in the USA have diabetes, diagnosed diabetes. That's about 1 in 10 individuals. And approximately, well, most of this is type 2 diabetes. And in South Africa, our latest statistics come from 2019, and we have about just under 4.6 million people diagnosed officially with type 2 diabetes. However, the most shocking statistic in South Africa currently I found, and you fell off my chair when I read it, was that about 67% of South Africans are pre-diabetic, and most of them actually don't know it. So if you're a diabetic, your risk of death is 50% higher, your medical costs are 4 times greater, and obviously the public sector costs are exorbitant. You don't die from high sugar, you die from the complications of diabetes. So heart disease, blindness, kidney failure, and of course there's the lower extremity amputations that come with it. So overall, diabetes basically places a huge burden on patients, the families of patients, the healthcare system, insurers, as well as the economy at large. And most of us know that diet is a major contributor to the problem. We eat highly processed inflammatory foods, such as industrial seed oils, refined grains, and sugar. And our day-to-day habits of sitting for hours on end, stressing for hours on end, not sleeping enough, not moving enough. These are not really how our bodies were designed to behave. And these behaviors, in turn, end up driving insulin resistance, which causes metabolic syndrome and type 2 diabetes. Carbohydrates are the major stimulator of insulin secretion, and a chronic excessive consumption of carbohydrates or calories drives insulin resistance directly. This leads to, obviously, insulin resistance in your liver, adipose tissue, and muscles. Carbohydrates also promote our hedonic eating, and this they trigger addiction-like neurochemical and behavioral responses towards food in us. They also significantly increase our sympathetic nervous system response. So this is the activation of our flight and fight hormones, which increase our anxiety and our blood pressure. And this chronically increased blood pressure, what happens then is that the muscle, our biggest glucose sink, basically cannot take up glucose fast enough from the blood because your capillaries are all constricted under the influence of blood pressure. And it also causes our liver to slow down its recycling of fat, so you get further fuel buildup in your bloodstream and further drives insulin resistance and diabetes, and all can promote it. It's not all doom and gloom though, because now we know that remission is actually possible. And however, with standard treatment, it's pretty rare, sitting at about 1%, and that's usually with bariatric surgery or severe calorie restriction. Pretty severe, if you know how many calories per day 850 is. And in terms of diet, given the effect that carbohydrates have on insulin resistance, we feel that severe carbohydrate restriction has the potential to put type 2 diabetes into remission. And indeed, over the last decade, there's been a relative explosion of literature, scientific literature, which have effectively stated that low carbohydrate diets are effective at treating type 2 diabetes. What are they? Well, they are swapping out your fats or your high carbohydrate content for healthy fat. So a moderate protein diet, so 20% protein, 70% healthy fat, and 10% carbohydrate. And compared to control diets, low carbohydrate diets consistently improve metabolic health. So how do they do this and why do they work? Well, effectively, if you're a diabetic and you go on a low carb diet, you will effectively increase your satiety because you'll be eating less to achieve the correct nutrient level. You'll shift your metabolism to a fat burning metabolic process. It's protein conserving and it uses fatty acids and ketones instead of glucose as your fuel. You're also gonna, because you're reducing your glucose load, not eating enough carbs, gonna get an increased insulin sensitivity to all your organs and tissues. You're also not going to get that sympathetic nervous system stimulation chronically, so less anxiety and high blood pressure. And you're also not going to get the addictive chocolate effect that carbohydrates have. So in effect, low carb, high fat diets promote the consumption of real food. And this can be medicine to a diabetic who's potentially poisoned by carbohydrates. So now, with that in mind, Sophia is going to talk to us about how we can maintain this diet.
Yeah, so even when we know what we should be eating, our feeling brain sometimes gets in the way of our thinking brain. And on a personal level, I'm sure we can all relate to the fact that lifestyle change is a huge challenge. Moreover, if you're a person living with diabetes and you are finger prick testing, there's a lot that happens with your glucose patterns over the day that you can miss if you're only checking, for example, in the morning, just reminding yourself that you have diabetes, or if you're not checking before and after a meal, there's a lot of information that you could potentially miss. So digital health monitoring technologies might offer us innovative solutions. They certainly promise that they solve all our problems. And if you think about from the perspective of the healthcare provider, they often have a very short time available to see you. They only see you every few months. So there's really a problem of frequency of feedback. And the promise of digital healthcare, the revolution here, is that it could potentially fill this gap. It's not clear, however, that more information necessarily translates into better health outcomes. So that was something we wanted to explain and understand better. So this is really a behavioral question. And when I discovered that Abbott's Freestyle Libre comes in two forms, one that hides information from you and one that lets you have real-time information, I was like, okay, this is dying for a behavioral experiment. We've got to do this. The interesting thing about a continuous glucose monitor, or a CGM, so when I first got into this project, they were super rare. And if you saw someone wearing them at the beach, you just like had to talk to them about it. Now everyone's kind of heard of them. They're much more common, but basically it's a little device. It's sitting on your arm. You can pop it on. It's minimally invasive. Even the patient can pop it on themselves. And they offer some amazing insights. So one of them is that the number of calories in a food, and we are obsessed with calories, it tells you nothing about the glucose spike that it can cause. Okay, so that's one insight that CGM offers. The other thing that's really fascinating after you start to wear one is that your stress, your sleep, and your physical activity also affect how you respond to different foods. So when we think about finger prick testing, there's sort of different barriers. We've got like a psychological barrier, we've got a pain barrier. And when you look at just general ad hoc like testing in the UK and in general in our sample as well, people test on average twice a day. And if you look at where they tend to test in the morning and not around meal times necessarily. And when you take away the sort of pain cost of monitoring and you give someone a CGM, they test a lot more. And this testing, the increase in testing, this increasing engagement really is what translates into better health outcomes, at least according to the observational data. And this data was mostly type 1s and type 2s injecting insulin. So we're looking at a different group of people, those who are not dependent on insulin injections, and those who are in this window of opportunity where you can really use nutrition to put diabetes into remission. So we don't understand going into this how it's going to affect our sample. So if we think, okay, more information is possible now, we have this available to us, is more information enough? Or Lauren will tell us about the missing ingredient for behavior change. You better unmute yourself, Lauren.
We're also thinking about and how we can support people with behavior change, not just with information. We'll see the role of information, the role that information has in our research, but we also are wondering about, well, what does a partner, a support partner, what role do they take? Conventional medicine evolved during a time when acute infectious disease were the leading cause of death, and today things aren't quite so simple, as both Kate and Sophia have spoken about. We're looking at lifestyle disease, and lifestyle disease is one of the main driver of our burden of disease in society. This is where health coaching comes in and motivational interviewing comes in, where we're health orientated, we're collaborative and patient-centered. You're really coming alongside the person when you're in a motivational interviewing conversation. And so in the research, we're wondering, well, what kind of support is best needed to support a patient to bring their diabetes, their type 2 diabetes, and nudge it into remission. So the next slide is, you'll see the question that we're asking ourselves. How do we support people engaging healthy food habits? And one of the privileges of research that we do is that we have an overview of the big picture statistics, but also of on the ground patient stories, and both their successes and their challenges. And you can see this is a client of mine with his permission. This was his post after 3 months of being on our trial, and very excited about the transformation that he's been on. We all have the same goal to take away our challenges with diabetes, and there's so many different lifestyle approaches, and often some that are quite controversial. And I think another interesting piece about this is that our food habits are culturally, historically, environmentally, logistically shaped, and they're highly personal to who we are as individuals. So it's what is it that works on the ground, not just in the big scheme of things, but what works in our diabetes clinic in South Africa. What works in one population may not necessarily work in another, but meeting people where they're at and coming alongside them in a partnership, like coaching type of way, can really support an individual's unique challenges and barriers. So will you tell us about the research, our methodology specifically?
Yeah, so as part of my PhD, I was lucky to get funding from the Max Planck Institute, and we set up this collaboration with a practice in Cape Town in South Africa, and we recruited 95 people living with type 2 diabetes in the range. They had a recent HbA1c test in the diabetes range, and they basically they knew upfront exactly the goals that we were going for. So our goal was to get their diabetes into remission. It was quite a bold goal, a challenge goal, but yeah, that was upfront. So let's go look at the design. Okay, so I'm a behavioral economist. My methodology is experiments. That's what I do. So we share this methodology with medicine. This is quite a simple horse race, if you think about it. So I'll break it down for you into 3 groups and 3 phases. So in our control group, which really gets a lot of support actually, because they also get nutrition education, we've got a control group, an info group, and a coach group. And the info group is designed to change one thing from the control group, and that is real-time information. And then going from the info group to the coach group, we're changing one thing only again, and we're adding health coaching. So in our baseline phase 1, we are getting essentially usual habits. We're capturing usual habits in our sample of 95 individuals. And everyone is wearing this amazing little device on their arm. It is not showing them any information. And as the participant, you're instructed to just continue as usual with your usual habits. You also answer some questionnaires about what you usually do. And then at the end of phase 1, that information is downloaded and shared with you for the first time. You sit down with the doctor and the diabetes nurse educator, and they explain to you the nutrition education that Kate will detail for you. And then basically, phase 2 is the key intervention phase. So we've got our nutrition education happening, and then you're going to be wearing either a control CGM or a real-time information CGM. And you're also going to be assigned to coaching or not. And then we allow for, this is an interesting thing in experiments, which often people neglect to do in the design. So we often look, did the experiment work? Did the intervention work? But here we allow for a washout period. So here we take away the CGM and we see what is the lasting effect. And then we're testing the bloods in the baseline period and right at the end after 3.5 months. So we randomly assign people to these groups. That's an important part of the methodology. And we stratified this on gender and also on the HbA1c level, so low, medium, and high. The idea is that at the end, if there are differences between the groups, it's due to the intervention that you were randomly assigned to and not to some individual characteristic of yours. However, as much as I love experiments and I can't get enough of them, they do have limitations. And what we should say up front is that when you get to personalized medicine, which essentially is happening here, tweaking of medications, personalizing, answering a question, there's so many little things that we should acknowledge up front and critique our own methodologies. So that's just something to keep in mind. It's not perfect control, and this is the real world that we're talking about.
Sorry. So as Sophia said, we ran this trial at a clinic, and the medicine in our trial was a low-carb, high-fat diet, and this is standard practice for type 2 diabetes treatment at this clinic. And everybody, all three groups, so the control, the info, and the coaching group, all got the same nutritional education from our doctors in an hour-long nutrition education session. They were advised to eat less than 10% of carbohydrates per day, which equates to about 25 grams of carbs. For some perspective, a small Snickers bar, I don't know how big they are in America, but here they're like this big, is about 55 grams of carbs. And we provided them with the Nutrition Network's endorsed green, orange, and red food list as a guide, as well as provided them with links to recipes. And both Sophia and I were in contact with everybody to help guide them. And they were allowed to eat as much as they wanted from the green list, moderately from the orange list, and never from the red list. Yeah. Sophia's going to tell you what the CGM looks like.
Yeah, so everyone gets some kind of CGM feedback. So we're not looking at the effect of a CGM, we're looking at the effect of real-time feedback. So we're isolating getting intermittent feedback from real-time feedback. That's the behavioral experiment here. If you're in the control group, and actually if you're in any group, you're going to get a report and you're going to sit down with the GP. This is actually mine. So I was eating a very boring, predictable diet at that point, which if you're interested, I can tell you exactly what I was eating. And you can't even tell when I was eating. But if you're starting off in our experiment, this is not what your data will look like. And there's plenty of room to improve. So yeah. All right. So Lauren was really involved in the protocol development from the beginning, and especially the coaching strategy and structure. And yeah, let's hear from her.
I was using the ADAPT model of coaching, which has motivational interviewing, positive psychology, and the trans-theoretical model of change as theoretical foundations for the coaching. All the sessions were done on Zoom, and each client in the beginning at their baseline period, we had a quick 20-minute establishing the rapport call. And then the first session was this hour-long vision session, which specifically focused on what is it that you're wanting to achieve, what does that end goal look like for you, and really getting into a space of what would they be most proud of, how this may impact their lives, and harnessing and evoking some of that internal motivation. Every subsequent session after that was just 30 minutes long. And we saw each other weekly for the first month. And then in that maintained period, it was once every 2 weeks. Each client also had access to support on WhatsApp and email support. There was a bit of motivation that went out via emails, both on a Monday and a Thursday. And these emails were also a place for us to give some information about different pillars of health, what might be supportive, not only around their eating, but other pillars of health that might support their diabetes. I think crucially is that every client was different. Each general session was very much client driven. What is it do they want to speak about? What challenges have come up for them this week? What wins are they celebrating this week? Where would they like to go on the journey that they're on right now? And I was standing alongside them and supporting them through that. The coaching tools. So the coaching tools that I used, and some of you may recognize a long-term goal-formed worksheet that was inspired by the MI session focus form. And this is giving people some options of things that they could focus on over the next 3 months. The low-carb eating was prescribed by the study and by their doctor, so that was in a big bubble. But depending on the person, they could pick what was important to them around their lifestyle. Was it intermittent fasting? Was it managing their stress? Was it focusing on some exercise? Another unique thing about the study and how we did it was that there was interaction with consent from the clients between the coach and the doctors, both the doctors and the nurse. They were given some updates on what was the challenge, what were the wins, and what was emerging for the client, and which they could address if the client wanted during the session. And this helped to bring about the sense of continuity of care and support from everyone in the practice. I want us to give a bit of time to pause to check if there are any questions. Anyone have any questions so far, either about something that you're curious about, like what has stood out to you already, or what is what is some of the things that have piqued your interest so far?
Continue to share often.
I might jump in just for a clarification, ladies. I think I saw there might have been a bit of a difference in what the carb ratios were. Did I see it was, I couldn't quite tell, is it less than 10% of the diet, or was it, what was the 45% that I think I saw South Africa?
So that's the standard recommended diet currently given to treat diabetes in South Africa.
Got it.
Just 35% carb.
Makes sense. Thanks for that clarification.
Pleasure. Sorry, that was confusing.
Raymond? We have a question from Raymond.
Yeah, I'd like to, if you could, share the what was in the green and the orange and the red.
Oh yeah, we can send that afterwards in an email if you'd like, or I can pop them here in the chat.
Thanks.
I'll share them. Anybody else?
Just a quick comment. It's very exciting and engaging. So, you know, I keep wanting to hear more. My thought is I'm appreciating everything you're doing, and I'm excited about the integration that you're talking about among the models, the trans-theoretical model, inquiry, appreciative inquiry, and positive psychology and MI. So I love that. And well, I'm only thinking at some point, if you formulate it as a unified model, so to speak, what it would look like, or if and when you do that, because you drew on elements of just all wonderful models, right? But obviously there were key things in some way that you thought each offered, and no one model was sufficient. So I applaud that and just encourage, I'm eager to see if it comes together in some way that we can read about.
Well, Lauren, you're going to have to write a methods paper.
The integrative model. Anyway, good work. It's exciting.
Yeah. Okay. Lauren, definitely. I know you've got a lot to say about that. And also, I just want to give a plug too for our upcoming March 2024 MI Med session, which will be the exploration of really what is health coaching and kind of this blending of this model that Lauren and her team speak of. But yeah, and how do they integrate? How are they separate? And definitely a little bit more. So that's just a teaser out there. And Lauren, say more.
Yeah, I mean, I think it's really interesting, and we'll see more as we're going through the study to see what kind of results are happening. We also made sure that we've recorded all of the sessions. So if we do want to do a follow-up, more of a qualitative study, what is actually happening in the coaching sessions that support behavior change? And yeah, I think I'll mention it as we go through how some of the different aspects of appreciative inquiry and TTM come up. But it's really an interesting space of how do we support people, but also be focused on different models and be agile depending on how people are presenting when they're sitting right in front of you.
Definitely. Okay. So we carry on.
Kate, do you want to share the lists now to respond to Raymond's question?
Oh, no, can I do that at the end or do...
Okay, sure. I mean, maybe you should just say briefly what's in each list. So the green list is the sort of whole animal-based proteins and leafy greens. And then the orange list is sort of for occasional consumption, and that's all the high carb fruits. And then the red list would be your super high carb foods, refined flour-based foods, pasta, rice, bread, that's off, all the good stuff. And then and processed foods, basically anything processed.
Yeah.
And vegetable oil, seed oils.
Yeah, but I'll pop them in at the end. I have to go find them in my computer somewhere still, so I don't have them on hand. Cool. Okay. I'm going to carry on to the key findings. So Sophia.
Yeah, so one striking thing, if you compare what happened in the study to just what one might expect from usual care, is that 46% of our participants entered the remission range. So that's quite an extraordinary result. They were starting at an average baseline HbA1c of 8%. That's the units that we're using in South Africa. And so entering remission means an HbA1c below 6.5%. At the time that we started the project, it was still quite an open debate on how to define remission. That's become clearer with time and published literature. Yeah. All right, so what the experiment is really designed to test is this horse race between our three models. So here we can clearly see an effect of coaching, but we should note that all three groups that received the nutrition education made a clinically significant reduction. So everyone did extremely well, and then we've got a very significant additional benefit of coaching here. We had two ways of measuring glucose control. So we had our HbA1c at the end, and we also had this sort of midline peek into how people were adopting and engaging with the nutrition education. So from the CGM, the continuous glucose monitor, we can see during the baseline, we're capturing usual habits. There's plenty of room for improvement. Everyone tends to be above the target range that we were going for. So our target range was a little more demanding than the consensus CGM range in the literature. And then as you can see in phase 2, the intervention phase, the average glucose comes down very nicely. And by the end of the first month after nutrition education and CGM, everyone's doing pretty well. So that's coming down nicely. And I think it's motivating for the patients to see that progress along the way.
Yeah, so all that gained control over their glucose levels and the tightening of their big error range throughout the day ended up generating pretty decent blood results and very good HbA1c results, as we saw. So this graph is just indicating the percentage change in the various lipids, so your cholesterol, LDL, HDL, and triglycerides, the HbA1c, and we also measured fasting insulin. And effectively, what we see is more compliance here. So on a low-carb, high-fat diet, we expected the lipid panels to go up. Not too much with the LDL, but hopefully that the HDL would. And most notably, we see that, again, the orange bars are the coaching group. And at the end of the day, these are the two metrics that mattered most to us. We wanted to see that the triglycerides came down and that the HbA1c came down. And it was most significant in the coaching group, and the info group, who only wore the real-time device, did most poorly. And coaching plus the real-time device led to better compliance to the medical advice that was prescribed. So we also looked at a number of other physiological measures, including blood pressure, because this is a primary healthcare outcome. And on switching to a low-carb diet, we expected less sympathetic nervous system activation. So we expected everybody's blood pressure to come down. And we expected for all changes for the coaching group to do the best, the info group to do second best, and the control to not feature. And this was mostly true. In fact, this is the only case where the control group had, I would say, the lesser performance out of the three groups. And coaching is still most significant. And then again, weight loss is very important when treating diabetes. Most people associate diabetes with being obese. And we expected, again, if they complied with the diet and followed the doctor's advice, that all measures of weight would decrease. So, and again, coaching to be the best and control to be the worst. However, we had no significant differences across any of the measures of weight, which was actually quite surprising. Here you can see there's a slightly better performance in our coaching group, but that amount of weight loss didn't really explain the differences that we saw in HbA1c. And I'm gonna basically put this back to you guys, and I don't know if you have any thoughts on why our info group, who had the real-time device, ended up with the worst clinical outcomes of our group. Not that they're bad compared to most normal clinical outcomes. I'm going to stop sharing and go back to another. I'll put that question to everybody, and maybe some people have some more comments or views to share on the blood results. If there are any. If there are none, I'll move on.
I think it's important to be upfront about what we expected, right? So if you had to bet on it, we certainly were. I mean, we pre-registered this trial. We should say that we would have bet that the real-time group outperformed the intermittent review of CGM, like hands down. We would have bet money on that. It was so interesting to see, like not the backlash exactly, but the unintended consequences associated with giving someone real-time access. And I think we experienced also in real time, like the questions and the concerns and the anxiety that came up for
Mm.
suddenly knowing too much about themselves.
Yeah.
I just,
Steve?
yeah, quick question here is what I think, if I understood the question correctly, is you have these striking outcomes in hemoglobin A1C, which is, and control glucose monitoring, which is the exact thing you're measuring and giving feedback on. So just a kind of, and you're saying, oh, we didn't see this the similar thing in weight loss. And I mean, just a high level responsible because you're not giving feedback on that. And my guess is that if you're giving feedback, or a question, if you're monitoring weight and giving feedback and coaching around it, you would expect the weight loss change.
So every time they checked in with the clinician, they would do a weight check. So they saw what their weight was doing. So, and I mean,
They did see it.
most of them were motivated by weight loss. And
Got it.
I mean, it's a huge motivating factor for a lot of people. And however, yeah, it doesn't explain the differences across the treatment groups.
So I might go back to what Lauren was saying about the qualitative and how much time in the coaching
Yeah.
session was spent around methods of weight loss.
Yeah, what surprised us that people who had the CGM and had all the information about their glucose did worse than the people who didn't have the CGM at all, who were just doing finger pricking tests. We really thought the more information people had, regardless of if they had a coach or not, the better that they would do. But then they did worse, and this really created some questions for us. Why is that happening? And I'm curious to hear from an MI perspective why we think that that may happen.
Lauren, did weight loss come up in many of your sessions or not?
No, not necessarily. Think, or at least maybe the end result of weight loss of like fitting into that skinny black dress came up for someone especially, and or fitting into those jeans. And I think society does have quite a focus on weight loss, but
not just society, medicine as well.
Medicine too.
Yeah.
But maybe Kate, we can go on and I can share some perspectives on why I think the coaching really supported.
Yeah, so we didn't just obviously measure all the clinical aspects. We also had some other secondary outcomes, which Soph can just take you through quickly, and just talking through the differences between the three groups on their psychological scale as well.
Yeah, so because we're looking at quite an interdisciplinary project, we also measured some surveys or some scales. One thing that we used was a food frequency questionnaire, and then we categorized the red list foods. So we wanted to see, was there a reduction in foods that we would categorize as avoid? And yes, there was. So people reported, at least they self-reported, that they were eating fewer portions per week from the red list. We didn't say, did you eat less of the red list? We asked them about individual foods. And yeah, we then did the categorization afterwards. Then obviously as a behavioral economist, I trust what happens in the objective measures, but I think it's super important to also see what people perceive as the change in behavior and also what they report themselves. So we saw an increase in happiness or subjective well-being across all three groups, but the significant difference in terms of treatment effects was with coaching and diabetes distress. So with the overall index, which comprises, other subscales like regimen distress, interpersonal family distress. From an overall perspective on the diabetes distress scale, we see a very significant effect of coaching here. And this could speak to one of the mechanisms of coaching. So it's quite nice to look into the black box, as it were. Yeah, there we go. let's hand over to Lauren.
Yeah, and then just coming back to this question is, why might more information have a negative impact on outcomes? And thanks, Jeff, for your comment in the chat box. I think we're exactly on the same line of thinking here. So what we found was, in many ways, the beginning of the trial, they were really kickstarted into action, and it was quite an intense, extreme lifestyle change that they had to make. They got the information about the diet, and then the very next day they had to put it into practice. And if we think of the trans-theoretical model of change, just no time for processing, very little time for planning, and then straight into action. And then they got all this information that they were getting from the CGM, and it really didn't mean much until they understood what the CGM was telling them, and linking their CGM to their food diary, and also having conversations with me and their medical team. But this space, and I love this graphic here, the space between data and information, it's all very confusing place for participants. Even this information space is quite confused. And this is where I see the coaching skills and the MI skills, especially around the heart set and mindset of motivational interviewing, played a huge role. I was surprised to see how overwhelmed and stressed people were. And that was often the focus of the sessions, that they would come in saying that there was a large amount of stress around it, and it would be expressed in different ways. So coaching around emotions was helpful. Helping them to name, tame, and reframe their experiences was also very helpful, and really getting them to a place where there was a lot more self-belief in their own skills and abilities and strengths to make the change. And then we get to this place of wisdom, I think, which was supportive by the end of the session, feeling like they had gained control over what the information they had was really telling them, and how they might apply this information into their daily lives. How might they do things differently going forward? What has gone well, what hasn't gone well, and what might they shift? And that's where I see kind of like the magic happening, when people feeling like they've gotten things under control, and they can put experiments into the new experiments into the week. And just to briefly conclude, and we'll take some more questions and thoughts, but basically we're saying that food can definitely be our medicine, especially around type 2 diabetes. And real-time information does not necessarily mean better health outcomes, but personalized support like coaching, motivational interviewing, and structured self-monitoring can get you quite far. And yeah, especially we're really pleased with the coaching results that we got such great results out of that coaching group, and looking forward to seeing where coaching and motivational interviewing, where we can go forward with supporting people to make long-lasting lifestyle changes. Thank you, everyone. Yeah, I think we're going to pause there and see if there, again, anything that's piqued your interest, your curiosity, any questions for us as we've wrapped up, and feel free to be as challenging and both challenging and kind. I think we do very well in motivational interviewing.
So, Lauren, can I ask a quick question? This is George.
Yeah, of course, George, go ahead.
Yeah, so were you the only coach, or were there other coaches?
Yeah, I was the only coach.
Okay, so because in MI we're interested in the training, and Stephen kind of offered the complexity of this integrated model and all the other things that went into this. If you were to replicate this, how would you train other coaches? If you were going to say, hey, we love this research, we would like to replicate this in our clinic.
Yeah, that's a great question. And I'm curious to hear both from Sophia and Kate if they have any thoughts, as well as Jody, because I was trained under the ADAPT model of coaching, which is an incredible model that takes account not only functional medicine information, but also the art and practice of coaching, which looks at those foundations of motivational interviewing, positive psychology, the TTM, appreciative inquiry, also looking at quite a bit around people's strengths. What is it that makes them tick? What do they love doing? And how do we incorporate their strengths into their ways of being? There was also quite a focus on mindfulness as a coach, to be mindful of my presence, to be mindful of different emotions that come up both for clients and how they're interacting with people, noticing patterns of stress. I think all of these come together and support a practitioner who's wanting to support behavior change. We also have a clear way of going through a session. We're setting the focus with the client. We're doing evoking. It's very, I think, and Jody, you can let me know if you think otherwise, but it's very much the model of the ADAPT model is very much aligned with the MI model, and is also aligned with the International Coaching Federation. So there is a lot of research that has gone into that too. And then it's what is it that the client wants to take away with them and experiment with in the weeks going ahead. Yeah, it's a really interesting one, this word, how do we replicate something? Because I'm an individual, they're an individual, there are things happening in their lives. I didn't have a script, I think that's the other way of doing it, is you have a script for every session, which takes away, I think, some of the magic of what we do here.
Yeah, I think I would love Lauren to come and train people. If I could get Lauren employed here, that would be the best goal. I think medical schemes are dying for more Laurens basically in South Africa. Everybody's punting the health coaching tagline, but I really don't think it's the same quality or level that we have with Lauren. I'm very grateful for her.
Yeah. Lauren, I have a question about, how much feedback from the doctors and from Tabi did you get when you shared the rosebud thorn communication with them? Or was it only through the patient, really?
It was just through the patient, so I was getting no information back from the practitioners. Yeah. Jody, I think you had something to say there.
I was just going to thank you, Lauren, and I was just going to concur with what you said. And George, what a provocative question! And isn't that the question we all have in Mint? Is how do we replicate this, and how do we continue to share our stories and lessons learned, which Steve and Heather have really said is our mission here in MI Med. So yes, I mean, and I think a big focus of our ADAPT program, which I had the privilege of being the executive director of for a number of years, was really challenging our students to do their own work, in what it's like to change and to walk through change, and what are the things that get in the way of change conversations, and what are the things that we can do or say or be that begin to open up that path for people to engage in their own self-change. And I'll put in another plug for the March session where we'll explore this a little more deeply. And I want to say explore because none of us have the answer, because there isn't one answer, but how do we explore that together? And I think I saw Raymond's hand up, and I know we're at the top of the hour. So I know those that do need to drop off, but we want to take all the questions that folks have before we conclude. So.
Well, mine is more of a statement because just a little over a year ago, I was in the doctor's office, and this was a new doctor to me, and talk about non-MI. He looked at me and and he found out that I have diabetes type 2, and I was put on a Libre 3, of which I've been wearing for the most part for over a year. But his first statement to me was, "You need to eat half of what you're eating." You know, and it's sort of like,
Okay.
that's not very. It's sort of like you need to go to MI school. But
All
then
doctors do.
oh my gosh, that
Sorry.
wasn't the best. But then I met with the nurse, and I found out that what I was eating was what we're told in the typical thing about what not to eat. In other words, cut out all the fats, get rid of all the fats out of your diet and stuff. And then I've come to find out that actually fats help you burn fat. And it's actually good for you. And I learned a whole bunch of things from the nurse that was a dietitian. And I ended up dropping 35 pounds in a year without starving myself at all. And mine was more of a keto carnivore diet, more on the carnivore side than the keto side. But I think a lot of folks are afraid of starving when they think about going on diets. And at least with this particular diet I was on, I didn't have to worry about starving myself. And my glucose monitoring 99% of the time was in range.
Nice.
So
well done, Raymond.
What an extraordinary story. Do you remember the CGM report that I showed you?
Yeah, we went by fast.
It's a very boring straight line.
Yes. Well, that's boring straight lines are good.
Yeah.
And I can tell when I eat something like noodles or something because my it just you can see it within 15 minutes. It just skyrockets. It's very educational, by the way. For people who have not been, even if they don't have diabetes, if they could get hold of like a Libre system or whatever other one, just to see what carbs do to your sugar.
And stress, I would say stress also does stuff to your sugar.
Following up on what Raymond said, I also was diagnosed with type 2 diabetes in the last couple of years, and it's crazy. Like it was like, okay, take all these medicines for your heart, your blood pressure. Even though my blood pressure was fine, it was just at risk because of the diabetes, and there was no talk of putting it in remission. Of course, I read a lot and worked on that through some of the strategies you discussed, but it was like it's mind-boggling how we don't have MI present in the healthcare facilities, and the focus is on, I mean, I guess it's reduced risk, but like, come on, let's food as medicine is a great strategy too. Like, I love this presentation.
Thank you, Heather. I was told by one of the staff in the hospital, I said, how do I get rid of this diabetes? And they said, once you got it, you can never get rid of it.
Right.
It's like, then I found out other ways to do it, and it's been in control.
Amazing. Thank you so much, both of you, for sharing. And well done.
Other questions or comments before we conclude? I feel like we've just scratched the surface. There's so much deeper, and I know you all probably feel the same way, and Kate and Lauren and Sophia. But other questions or comments before we wrap? If not,
just a quick comment for Lauren. ICME is the International Conference on Motivational Interviewing. It's held every couple of years. It's a Mint science. Well, it's open to anybody outside of Mint as well, but it's a sort of MI science conference.
Great.
It's usually virtual.
Yeah. I mean, I think I can speak on behalf of both Kate and Sophia and I that we'd love to share this research. It's on its way to publication, but the more discussions we can have about it and support behavior change, I think the better. So yeah, I'd love to get involved in that. And if anyone has any contacts for us, that would be great.
Actually, Jody and the group, and in hearing about this presentation, I'm very interested in the ADAPT model. I asked that question before about, now I see it, I said that you put it together, I see there is a framework that is an organizing one. So just my plug, Jody, who would do it, I'm not sure, but for this group to hear what those elements of TTM, positive psychology, have added to what we learn in MI school, to get to adapt would be a lovely kind of MI Med presentation at some point.
Well, perfect. We will put that on our list, and Lauren, put it on your to-do list. We'll get you involved here. And with that, just really want to say congratulations to Sophia, Lauren, and Kate on your extraordinary work and such interesting outcomes that really do support what we know in MI is that autonomy support and understanding what matters to a person matters a whole lot more than just providing the information. So thank you. And I know we want to continue to say one of the things I would always tell our students in the ADAPT program was ripple on, because the work that we do has ripples out to the world. And how is it that we change our world? It's one conversation at a time. And these are such important conversations. And so thank you. Congratulations for your work. And I know we'd love to have you back to do a deeper dive at some point. But thank you so much for taking the time today to share your stories and helping us learn how to be better and to grow better. And I am going to put in one more plug for we've got a March meeting coming up and then a May meeting coming up. These will both be on the third Monday, so March 18th at noon Central Time and May 20th at noon Eastern Time. We will reconvene, and our March meeting will be a little bit more on the ADAPT model, but more on what is health coaching and what ties does it have to motivational interviewing. So again, a discussion, no answers, but solutions sought, lessons learned. So thanks to Steve and to Heather for their wisdom in getting this group started and their leadership in it. So hope to see you all again very, very soon. And thanks so much to our presenters, Lauren, Sophia, and Kate.